Well, welcome again to another episode of the interviews with the experts here at Mayo Clinic. I'm Malcolm Bell, your host today, and I'm delighted to have my colleague, Dr. Patty Pellikka, joining us today. Dr. Pellikka is a former chair of the Division of Cardiovascular Ultrasound. She's also currently the editor-in-chief of the Journal of the American Society of Echocardiography. So welcome, Patty.
Thank you, Malcolm. Nice to see you.
Yeah, and we're here to discuss a recent study that you and your collaborators, that I note many international collaborators, recently published, but it's a work you related to AI-assisted algorithm to assist in the diagnosis of cardiac amyloidosis. You know, another example of how AI can help with the diagnosis of cardiac diseases. So, again, this is really an intriguing and fascinating topic, and I just wonder if you could tell us, you can tell us more about this screening tool, but really as a background, how did you get into this? I mean, why did you explore this? And recognizing that, you know, echo has really sort of been a pivotal tool in the diagnosis of amyloidosis, particularly early on. But maybe you give us, again, some background as to how you got into this.
Well, thanks, Malcolm. Yes, I was involved with the project, the AI ECG project, to detect reduced ejection fraction less than 35% by a standard 12-lead ECG. And that got me to thinking about what we could do if we applied AI to echocardiography, which contains, of course, so much information, you know, sometimes 500 megabytes in a single study. So when the American Society of Echocardiography Foundation put out a call for grants, I applied for a grant to apply AI to build a deep learning model to apply AI to echo images to detect HFpEF. And I chose that because diastolic function is such a conundrum. We spend so much time trying to evaluate it in the echo lab, and it's so important clinically. So that was my plan, and that I received the grant, and we built the model. It was approved by the FDA and by their breakthrough pathway. This was a collaboration with an AI echo company. And then the next logical thing to build seemed to be a model to detect amyloid cardiomyopathy. That is also a difficult diagnosis, and we're capable of missing the disease. We now have treatments for cardiac amyloidosis, so it's important not to miss it. And that was the focus of our next study.
You know, and you made the point that you know, you don't want to miss amyloidosis. It's easily missed, and you know, up until recent years, of course, it's not always been easy to diagnose, and very often we don't even suspect the disease. But as we all know, there are other you know, newer imaging, you know, particularly with you know, transthyretin and with nuclear scanning. But we also have treatments now, you know, and that will improve outcome in patients. So it's become very, very important. So tell us about this model that you built. I mean, and then how did you validate this against presumably other scores which incorporate the echocardiography?
Yes. Well, we built the model hypothesizing that we would be able to detect both HFpEF and both amyloidosis from an apical 4-chamber view, just that single view and no other information. Of course, that view contains so much information. You can see the wall thicknesses, valve motion of the mitral and tricuspid annulus. That apical 4-chamber view contains so much information, as well as systolic function. So that was the view that we used, and we trained our amyloid model using about 1,300 patients with amyloid and a similar number of controls with conditions that might be phenotypic mimics of amyloid, including hypertensive heart disease, aortic stenosis, hypertrophic cardiomyopathy, as well as other patients without thick walls, including patients with HFpEF. So that was the model that we built, training the computer with these carefully labeled amyloid cases and controls. And then we validated it with international data from 18 sites using various ultrasound systems and all these various centers. And we're able to establish that the model had an AUC of 0.93, and that was in a population with a 22% prevalence of cardiac amyloidosis. Sensitivity was 85%. Sensitivity was not impacted by the type of amyloid cardiomyopathy. Specificity was also very good at 93%. And the performance of the model was very good among AL, wild type, and hereditary amyloidosis. Then we wanted to see if it helps us compared to clinical tools, the clinical scoring systems that we currently use to estimate whether someone might have cardiac amyloidosis. And for that, we used the transthyretin cardiac amyloid score, which was validated at Mayo Clinic. That uses a variety of clinical variables as well as echocardiographic variables to assign a particular score about the likelihood of amyloid. And then we also compared it against the increased wall thickness score, or Baldrini score, which includes echo variables as well as clinical variables. And the echo variables there include strain and EDE prime, the base to apical strain ratio, and TAPSE. So our model was superior to those models for identifying patients with amyloid cardiomyopathy.
I mean, certainly an AUC of 0.93 is really impressive, isn't it? I mean, we don't see a lot of screening tools for most diseases, above 0.9. So this is really impressive. And I guess similar to what we saw with the AI ECG, assessing LV dysfunction. You were talking about the transthyretin cases, wild type, hereditary, etc. I'm not sure you mentioned light chain disease, amyloid. I mean, these were cases also included in your patient population?
Yes, we trained the model to just detect amyloid cardiomyopathy without differentiating the types. But it is possible that it might be able to be further refined or trained to even differentiate the types.
Did it seem to be equally accurate for each of those types?
Yes. The sensitivity ranged from 84% to 86% across all the types.
And obviously this was a retrospective study. Did you have cases in there that were very, very early amyloid that may have been missed, completely, not even suspected? And I mean, I'm not sure how you'd identify those, but did you find any of those in your study?
Yeah, that's a great question. We tried to pick the earliest case in which amyloid cardiomyopathy was detected in order to train our model. I think that that's important because a very advanced case of amyloid cardiomyopathy might be easily recognized, and we didn't want to make a model that would be unsophisticated or only be able to detect late disease.
As you look at this, what the potential, again, obviously a very well conducted, study, large patient population, and it sounds though you had patients from outside of the United States, and so lots of different ethnicities, I assume. When you look forward, Patty, is this an algorithm that you would just leave on all the time, or is it an algorithm you turn on and off, depending on what your suspicion would be in a busy echo lab? And again, I'm just trying to think that you got patients that you're suspecting and you want to maybe accelerate the diagnostic algorithm or pathway for these patients. And so this would be really helpful. But as you said, you talked about patients with LVH, for example, aortic stenosis, other diseases that may cause increased thickening. So who would you target? Is it on all the time, or is it just selected patients? And if so, which patients would you be selecting?
That is an interesting question, and we still have to learn more about that. But I can tell you how this FDA-approved model is being used throughout the United States now. It's being applied to, in some institutions, all comers, and then those in which it is positive for HFpEF, the amyloid algorithm, is also being run. But we need more information about age limits, age parameters. Perhaps this is best applied to people over the age of 55, for example. And perhaps adding some parameters for wall thickness or HFpEF will make it the most effective and appropriate use of the technology. We also want to study it to see if it identifies the patient's response to treatment and patients that may be most appropriate for one therapy versus another. There's so much left to learn. It's super exciting.
Yeah, it truly is. And obviously this was a very selected, carefully selected, population. In people's current experience with it, and certainly looking forward, when we think about in the real world, I mean, obviously the prevalence of cardiac amyloidosis then is going to be lower than what was in your study. Do you have plans to look at this going forward in real world patients, or even any randomized study to see how it really performs in terms of cost effectiveness, accuracy?
Yes. Yes, indeed. I think we need to be conducting these studies and are looking at a variety of options to continue this line of research. But with our decision curve analysis that we did report in our European Heart Journal paper, we were able to identify more cardiac amyloidosis patients correctly with our algorithm compared to these clinical scores. So it would mean about 36% more patients correctly classified and fewer referrals to PYP, for example. I think it's important to think of these strategies and how to practice most efficiently and cost effectively, and also to save our patients from any unnecessary radiation exposure.
Yeah, but also clearly identifying the patients who are going to benefit from treatments that are available. And as we both know, and our listeners know from experience, we often overlook this, diagnosis, and too often it's not made until quite late in the disease progression. Patty, we're sort of running out of time here. I don't know if there's any other points you want to make before we wrap up here.
No, I think it's truly exciting that we can now be able to detect disease from a single apical 4-chamber view that could be acquired potentially with a point-of-care device. And it can really extend the reach of echocardiography beyond the walls of our institution.
Yeah, in fact, I was going to ask you about point of care and whether it's going to be applied there. It may be too early, obviously, but even the image quality and getting the the right views and as I understand, there are methods now sort of to try to optimize those views, and it would probably also increase the accuracy of this perhaps even further. So I really want to thank you for taking the time to share this experience. And again, congratulations on the work that you and your colleagues have achieved and with that recent publication. I think this is just another really intriguing and exciting example of how the emerging AI-assisted algorithms can help with more accurate diagnostic testing and particularly with cardiovascular diseases. So once again, thank you so much.
Thank you, Malcolm.
Well, thank you. And thanks again to our viewers and listeners for joining us in another of this series of interviews with the experts. I look forward to presenting other colleagues and their work in the future.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Mark Moline, Wound Clinic Director of the Gonda Vascular Center at Mayo Clinic in Rochester, Minnesota. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Head to cveducationmayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses, all created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.